Chitra, I just sent you my thing as a backup. Okay, my presentation. Chitra?
3, 2, 1. We are live now, ma'am.
Okay.
A very good evening to one and all. So I'm very privileged to invite everyone for this IFS Tamilnadu chapters webinar, which is happening on the 21st of July, Friday. So I would like to, give all the credits and honor for involving me in this to my secretary, Tamilnadu chapter, Dr. Rajapriya Madam, and Dr. Priya Kannan Madam. I'm Dr. Priya Kannappan. I'm a consultant in Mehta Hospital. So today I'll be the convener for the day. Next slide, please. Yes. So I would request Dr. Rajapriya Madam. She is the Managing Director our Home Fertility Center in Srinivasa Priya Hospital, Perambur. Madam is a Executive Committee member of ATN RCOG, a Managing Committee member of OXY, and she is in FOXY Endometriosis Committee now, a Secretary Perambur IMA Wing, and a very active participant of the IFS and the Secretary as well. And Madam, for you for the welcome address.
Good afternoon to each and every one of you who have managed to log in to find time this beautiful Friday afternoon. Every third Friday, IFS Tamilnadu holds a webinar. And this week, we are excited that we have three fantastic speakers. We have Dr. Satya, Dr. Sujata, and Dr. Nandita to have joined us for the afternoon. And we have a variety of topics: gonadotrophins in IUI, IUI in suboptimal semen sample, and unconventional indications for IUI. IUI is something which we do on day-to-day practice as a basic fertility intervention. So without further delay, I would request my co-chairperson to be introduced by Dr. Priya Kannappan. I'm glad that all of you could make it this afternoon to attend this webinar.
Thank you, Madam. So it is my privilege to invite Dr. Bhuvneshwari Madam. Madam is the Medical Director of GBR Fertility Center, and she is also the Director of Institute of Reproductive Medicine at Railas Hospital, a fertility expert, a laparoscopic surgeon, a certified robotic surgeon. Madam has presented many papers in every conferences, and as well she's been member in all the societies. You can just see the names yourself. And Madam has been involved in the teaching of ICOG as well as a postdoctoral fellowship, and she has a special interest in robotic surgery, stem cell therapy, uterine transplant. So all the recent advances, so she'll be the right person. So over to the chairperson, Madam. Madam, I would request you to invite our first speaker, Dr. Satya. Dr. Bhuvneshwari, Madam.
Thank you, Priya. Thank you, Rajapriya, for giving me this opportunity. And it is nice to know always Priyas are associated with IFS. Now, I have my privilege to invite our first speaker, Dr. Satya. He is a clinical director in the Cloud9 Fertility from Chennai. And he has been trained in reproductive medicine at CMC Vellore, one of the known reputed institute. And he has been involved in teaching and training for postdoctoral fellows from 2005 onwards. He has been an examiner for FNB and in MRCOG exams in many centers. He has been conferred FRCOG in 2019. He is a very good friend of us, and I'm sure he will be able to tell us what is new and how can we use the gonadotrophins efficiently and safely in our day-to-day IUI practice. We welcome Dr. Satya.
Thank you, Dr. Bhuvneshwari. I'm just trying.
Sir, are you sharing your screen, sir?
Yeah. Can you see it?
No, sir, not yet.
Not yet. So I'm just trying. I'm not used to this conference online kind of thing. I never go for this. So I'm kind of, just give me a minute. I will sort things out.
Sure, sir, sure. So till that time, we can just give you an intro of like why we came with these topics, because people are like so used to hearing about IUIs. Every topic about IUIs already been explored maybe some hundreds or thousands of times. So we chose the right people to come and give us insight on topics which have never been touched. So that is why the topics are quite different. Yes, sir, we can see your slide.
Yeah.
Can we go for the slideshow, sir?
Yeah. Okay, let me just get started. Some issue.
The down arrow, the slideshow can be like near the 68. Can we click on that, sir? When you come down.
Yeah, now I got it.
Yes.
All right. So thank you very much. As I told you, I hardly ever go to these conferences, so I'm a little rusty with all these things. My talk will be very brief and
Sorry to interrupt, sir.
Yeah, it's
Your
not yet come in
slides
the slideshow mode.
Sir, can you please stop share and share once again? You don't select on the screen. Sorry, select on the PowerPoint. Select on the screen, sir.
all right.
Yeah.
Is it okay now?
Yeah, fine. Just
Yes,
have
sir.
to put the
Perfect,
first
sir.
slide. Yeah.
All right. So the commonly used protocol is a combination of an ovulation agent and HMG. We usually would give letrozole 2.5 milligrams from day 2 to day 6 and injection HMG 75 units on day 5, 7, and 9 and call the patient back on day 10. This is, I think everyone knows this. We continue injection HMG till the lead follicle reaches about 18 millimeters. It is equivalent whether we do HMG or SSH. There's no evidence that one is better than the other, even in PCO or whatever be the case. So trigger ovulation is usually given with HCG 5000 international units, or if there are little more number of follicles, and we want to prevent a hyperstimulation, we can give injection triptorelin 0.2 mg subcutaneously. When we use triptorelin, we know that we are further compromising the chance of success. So you give a modified luteal support, including estrogen and progesterone. We usually plan for IUI after 36 hours, and it's better to confirm ovulation before we go further. I don't know what is happening. Yeah, variation. So that was a conventional one that I described. But if the woman is overweight or obese, we might want to increase the dose to about 150 units, but seldom more than this. So if somebody is not responding to 150, then we have to either recommend weight loss if she is obese or seriously consider about conversion to IVF. So these are the two things. Of course, there are other modalities like increasing the dose of letrozole or giving an insulin sensitizer for a couple of months to get her to become more insulin sensitive. Right. So in obese and overweight patients, we can do this day 5, 7, and 9 with injection HMG. As the dose increases, the risk of multiple pregnancy and OHSS also increases. If there are more than 5 follicles, and majority of the Western studies they quote as 2, then it's recommended that the cycle is cancelled. Alternatively, we can trigger with triptorelin in case the follicle numbers are more. Do a follicular aspiration, leaving behind 2 or 3 follicles and perform an IUI. In case very large number of follicles like above 8, 10, and so on, then discuss conversion to IVF after giving an antagonist. So this gives equally good results compared to conventional IVF. It's going in a reverse right. So when would you want to cancel the cycle? As we said, if we have very large number of follicles and we are wanting to avoid a multiple pregnancy, when the estradiol levels on the day of trigger is more than 3000, these are all indications that you may warrant a cycle cancellation. So what do you do in such a scenario? You don't give any further gonadotropin, don't give an ovulation trigger, and the couple should abstain. This is another protocol that's recommended in lean clomiphene resistant PCOS, where it's recommended to start with the FSH 50 units and increase every week based on ultrasound report. It's usually long and cumbersome, but it's good for monofollicular development. So the increments will also be in 50 units after every week. And once we reach the regular 18 millimeters, we would then trigger. Now, I just thought I'll look at literature review, and I'm just presenting it as points because presenting each of the studies would take a lot of your time. So the general consensus now is the total motile count, sperm count, should be more than 5 million for an IUI. letrozole or clomiphene is sufficient in those with ovulatory cycles. There's no need to add gonadotrophins every time. Outcomes are similar in case of spontaneous ovulation or with ovulation trigger. Most of these have come from randomized controlled trials or meta-analysis. So I just want you to know that what I'm presenting now is all evidence-based. In unexplained infertility, 3 to 4 IUI cycles are only recommended because thereafter the cumulative chance of getting pregnancy comes down, and this should be followed by IVF. Women over 40 years of age need to know that the live birth rate per cycle of IUI will be less than 4%. Knowing this number might help them to decide whether to do IUI or to go with IVF. And if they do over 6 cycles, still the live birth rates are only between 3.6 to 7%. IVF in the same group, success rates are not too great, but still better at 9.2 to 20%. Any woman above 45 years should be told about donor oocyte program even earlier, but definitely at 45 and above because majority of the oocytes or almost 100% of the oocytes may be aneuploid. So clomiphene cycles, it's been found that the trigger at 20 millimeters lead follicle size is better than at 18 millimeters, which we use for gonadotropin cycle. Rescue IVF in hyper-responders, we have to give antagonist and then trigger either with HCG or triptorelin based on the follicular numbers and estradiol. So if your estradiol levels are more than 3000 picograms per ml, it's safer to go with the triptorelin 0.2 mg or 0.3 mg subcutaneous. Outcomes are equivalent to conventional IVF cycle, even in rescue IVF cycle. Also, whether checking for LH surge help, because there are some clinicians who feel that it's advantageous to check LH frequently. So according to evidence, spontaneous LH surge or even lack of it, if you give a trigger, did not affect the probability of success in IUI. In unexplained infertility, ovarian stimulation with IUI has a higher live birth with increasing endometrial thickness. However, appreciable live births are still seen in the less than 5 millimeter group in clomiphene or letrozole cycles. So the thin endometrium by itself should not be an indication to abandon the cycle. And then low dose gonadotrophins is better than clomiphene alone. A non-obese patient, 37.5 is equivalent to 75 units. So you can choose to start with a lower dose if you so desire. There is no higher risk of hyperstimulation at 75. So if you're happy with 75, you can start with it. Similarly, giving highly purified HMG and comparing with recombinant FSH and recombinant LH found no difference in IUI pregnancy rates. And Cochrane says that ovarian stimulation with IUI is better than expectant management. Natural cycle IUI is better than timed intercourse. And superovulation and IUI is better than natural cycle IUI. So these are more or less things that we already know, but when Cochrane says it, it has a higher weightage. So to conclude, adding gonadotrophins to oral agents increases the probability of live birth. In non-obese PCOS, low-dose gonadotrophins give equally good outcomes. There is no advantage of checking for LH surge. Appropriate use of trigger agents and doses minimize the risk of OHSS. And cycle cancellation or rescue IVF are both effective and safe measures in hyperesthesia. Thank you.
Thank you, Dr. Satya. If I may ask you a question, like usually you start with 75 units, either HMG or FSH, and say by the time day 14 or day 16 happens, no follicle is coming up. Would you consider thinking about the wave theory and adding on more gonadotrophins in that cycle, or would you prefer to wait on to the next cycle to increase the dose or the duration of gonadotrophins?
I would like to discuss with the patient, but I think there's a case to be made to continue with increased gonadotropin dose in the same cycle, at least for another 5 days. If not a lot is happening, then maybe we can call it good.
Right. Then what would the usual number of follicles you would want? Like, would you want to go up to 2 follicles or 3 to have a
Yeah.
better outcome? How would your calculation of gonadotrophins be?
I think 2 or 3 follicles is comfortable number to have. And in fact, if there's only 1 follicle, I discussed with the patient that there's not a whole lot to gain by doing an IUI. They might as well try on their own in that case. So if it's 2 or 3, it's good. If it's much more than that, then we discuss other options like follicle aspiration and IUI.
What's the maximum dose you would go for? Like, would you even venture into 150 or 200 units for a short duration? If it's a resistant.
150, I definitely go. But if 150 after say 6 or 7 days, a week or so, nothing is happening, then I would stop it and then maybe consider to start with 225 from day 2, counseling them that there will be probable need to convert to IVF treatment.
Thank you so much. Are there any more questions, Priya, in the chat box or something?
No, ma'am, in the chat box, we don't have questions. So do you routinely evaluate the tubal test before going in for IUIs? Is that like something, you do it as a part of the routine?
Yeah,
Before-
whenever we start gonadotrophins, before that we need to have the tubal assessment done. That's standard.
Good afternoon. Excellent talk, Dr. Satya. I just want to ask you, in a PCOS patient, like a normal LH, what is this type of FSH or HMG? What gonadotrophins you would prefer? Do you prefer only FSH or is it okay to start? Because you have said in a paper, whether it is highly purified or urinary or whatever, gonadotrophins are same. But generally, practically, is it okay to start if the patient is affordable? I'm saying the cost here, I'm not talking. If the patient is indicated a PCOS patient, we are going ahead with the IUI. Should we start with FSH or it is not required at all? Is there any paper comparing only FSH? Is there anything related to success rate?
Yeah, there are. These are all what I presented was trials which were done. And in my own practice, I never use FSH in IUI cycles. So always
Okay.
HMG only.
Okay.
And even
So
in-
would you cancel if they get like no, if you're giving more FSH or highly purified, whichever chondrotrophin, if you get more follicle on one side, 3 follicle, other side 2, 3 follicles, most of them are around 16, 17 dominant already. Would
Yeah.
you cancel or can we go ahead with the added risk, informing to the patient that we know there is a risk of multiple pregnancy with the gonadotrophins, even with the 3 follicles or 2 follicles?
Yeah,
So
because
what would we
I
suggest?
work in an IVF unit, Dr. Bona, as you know, so I also discussed with them about
Okay.
follicle aspiration and IUI. So we
Okay.
aspirate follicles, leave behind 3 or 4, and then do the IUI.
Okay. So would you freeze that, those oocytes? What do you do with that oocytes?
Because
Aspirate?
there's nothing is planned, no, they're not paying for oocyte freezing.
Oh, so you just
Just get it started.
okay, okay. Thank you so much.
Thank you, Dr. Bona.
So sorry, sir, if I misunderstood, like you told us, you will aspirate the follicle, you will discard the oocyte, like the extra ones, and leave behind 2 or 3 for them to go ahead with IUI.
Yeah.
Okay.
On the same
And
day.
or if the patient allows, if she's affordable, if she wants to do IVF, then you go ahead and do
Yeah,
something
yeah.
with that follicle as well.
Of course,
I mean, the
both
oocyte.
options are discussed, but many a time patients are not mentally prepared and financially prepared for IVF. So then we try this out.
So what you're trying to do is you don't waste a cycle at all points. You make sure that the IUI happens, taking the risk of hyperstimulation or whatever. So that's nice to know that you don't. Sometimes a lot of us look at the point of cancellation of a cycle. It's lovely to know that, Dr. Satya, you don't allow the cycle to get cancelled. Just aspirate, give them the required amount of follicles and help them to complete the IUI program. That's lovely. So this is done under anesthesia, right? The
Yes.
aspiration.
The same thing, regular egg collection kind of procedure.
Yeah. Thank you so much. That was
Thank you,
interesting.
thank you so much.
Thank you, Dr. Satya. So now I would request Dr. Rajapriya Madam to introduce our next speaker. Sir, can you?
There is one question. There is one.
Yes, ma'am.
Priya,
Yes,
there is
ma'am.
one question in the box.
In my
Dr.
chat,
Satya,
it's
you can
not
stop
there.
sharing, Dr. Satya.
Oh, okay, okay.
It says how many days once you would increase the dose of HMG. Supposing we have to give HMG 75 on day 5, 6, 7, 8, 9, and no follicle is noted. That's one question in the chat box.
On day 10, we would look at the size of the follicles. If they are still less than 10 millimeters, that means they're totally unstimulated. So we are justified in hiking up the dose. The follicles are already like 12 to 14 millimeters, and we can just continue with 75, and it should eventually reach there.
There's one more question. Patient with PC on letrozole with gonadotropin, no follicle up to day 14. Would you continue gonadotropin even after day 14 or beyond?
Why not? If this so far no follicle growth, that means it's as good as day 2 for that particular patient. So we can definitely go ahead.
Those were the only two questions.
Thank you, Dr. Nandita.
Thank you, Dr. Satya. Can we have Dr. Sujata's CV?
Chitrakala, are you sharing the screen?
Looking at today's scenario, most of the time we have a suboptimal semen sample, right? Either we have a struggle with the count or the motility, and maybe that's one of the important reasons why we do IUI. And who better can we have than Dr. Sujata to talk about it? She's the head embryology, Nova IVF, a very good friend who would always say yes to any topic because of her immense 25 years experience. She's also held good positions at Kraft and Cloud9. And we have the American board certification by her. And currently she is the vice president of the Academy of Clinical Embryologists, ACE. And here we would be eagerly waiting to listen on an ACE talk on handling suboptimal semen sample. Dr. Sujata.
Thank you very much for the kind introduction. Good afternoon, everybody. Just give me a second.
Yes, ma'am. Your screen is seen, ma'am. Yes. Yes, ma'am.
So thank you very much, IFS team, for having me here this afternoon. So the topic is IUI in suboptimal semen sample. And the scope of this presentation is, I would just start with a little bit on the introduction, the background, whatever it is. And before we move on to the sperm processing techniques, I would like to talk a little bit about sperm parameters and IUI success. What is, what do we know from the literature? Then we'll move on to the sperm processing techniques, especially in suboptimal semen samples. And generally we get questions such as, what is the influence of centrifugation, and how do you store the sample before insemination and all that. So I have, discussed few points on this and a summary. So IUI, we know that is the first choice of treatment, especially in case of unexplained infertility, when there is, moderate male factor subfertility. This is very important. And when we also know that there is an unfavorable prognosis for natural conception in these cases. Now, why do we wash the semen sample? Because we need to separate motile sperm, which is morphologically normal, from the seminal plasma. And seminal plasma is, it contains all kinds of cells, and it also has a lot of debris and immotile sperm cells, WBC, so on and so forth. Now, why do we have to remove from this? Because, these studies were done much, much earlier in the early 90s, where they found that if you have these kind of contaminants in the semen sample, and if they are left along with the sperm, then it reduces the fertilizing capability of the sperm. So it is mandatory that we remove all the contaminants from the semen sample. That is the reason for washing the semen sample. Now, so as I said, before we even do an IUI, it's better to have an idea about the sperm parameters and what kind of success can be expected. So when I say can be expected, it doesn't mean that if it doesn't fall within this criteria that you will never get success in IUI. This is, the majority of the cases would fall within this range. Lot of retrospective studies, again, from the early 90s, and they have analyzed the cycle outcome based on sperm parameters across a variety of ovulation induction regimens and infertility diagnosis. And it has been found that like you should have a cutoff of total motile sperm concentration of 5 to 10 million. Now, again, like see here, we cannot, this is not a conclusive number because of the reason which was mentioned earlier, that all these studies were done across a variety of ovulation induction. So, that definitely has its effect. And second, the infertility diagnosis also matters. However, generally, like you should have a total motile concentration of 5 to 10 million. Now, there is one particular study which I would like to quote, which was done in 2001. And this is a large study involving 1,039 couples who were less than 43 years of age and who underwent 3,479 IUI cycles. They were either natural cycles or ovulation induction with gonadotropins or clomiphene citrate. And it was found that the pregnancy rate increased, or the threshold was at 10 million, and less than 10 million, the pregnancy rate was 1.5% compared to when the total motile concentration was 10 to 30 million, it was 10.5%, and it was over 30 million, it was 12%. Now here, when I say total motile concentration, this is the concentration of sperm in the ejaculate, not the concentration which we are inseminating. Okay, so this is the starting point. Now, if you go and look at the sample, the post-wash sperm count, here again, the relationship has been studied across a variety of programs. And this is one retrospective cohort study from a single large fertility clinic. And it's a huge study where, 92,471 cycles were analyzed in 37,553 patients. And what they have reported was the clinical pregnancy rate was highest when the total motile sperm concentration, that is the post-wash count, was greater than 9 million. And there was a gradual linear decline in clinical pregnancy rate as the total motile sperm concentration decreased. So if you look at the table, it just tells you that when the concentration was over 9 million, it was 16%. And then when it was less than 0.25 million, it was only 4%. So this actually gives us an idea that what should we aim to get from a post-wash. So our method of processing will be based on this. So from any sample, we should be able to get something like this in the range of this concentration, which actually, can tell us that success, IUI success can be achieved. Now, when you start with sperm processing, like this is for all semen samples, but especially if the sample is a suboptimal one, then, it is mandatory that we start as early as possible. So within 30 minutes of ejaculation, the capacity, the fertilization capacity of the sperm starts to diminish actually. So, the more time you keep it along with the seminal plasma on the laboratory bench, then the sperm will not be able to fertilize an egg. And WHO actually recommends that separating sperm cells from the seminal plasma within 1 hour of ejaculation, so that it can actually limit the damage from the leukocytes and other cells present in the semen sample. So this is the first one. Now, choice of methods. Actually, this is based on the quality of the semen sample, the concentration, motility, and morphology of the sample. However, our aim is to get a good number of spermatozoa, even from the poorest sperm. And we know that we should get somewhere in the range of 9 million sperm insemination concentration. Now, what are the two methods by which we can achieve this? One is density gradient centrifugation, and the second one is simple washing. We are not talking about swim up here, because swim up is only for normozoospermic sample where the count, motility, and morphology is good. Or in suboptimal samples, if it is for IVF or ICSI, we can still consider swim up. But since we're talking about sample for IUI, then these are the only two methods which can be used. Now, density gradient centrifugation, it actually separates sperm cell based on the sperm density. So what happens is, as you see in the picture, there are colloidal silica solutions. A higher density solution is layered at the bottom, Over that, a slightly lower density is layered, and on top of it, the semen sample is placed. And the tube is centrifuged. Now, what happens at the end of centrifugation? Spermatozoa, based on its density, of the fluid, will get settled. And it is shown that a mature, morphologically normal spermatozoa has a density of around 1.10. That has the highest density, and hence it will get settled at the bottom here. Whereas an immature one, morphologically abnormal spermatozoa, has a density of around 1.06 to 1.09. It's slightly lower than the mature one. It actually will settle somewhere here in the second, in this layer. So this is the principle. And then we gently remove all these things and use the sperm, which is settled at the bottom of the tube, for the insemination process. So this is the principle behind density gradient centrifugation. Now, so key things to be kept in mind: the centrifugal force and time should be kept at the lowest possible values. This is because, like you do not want to generate free radicals. And, like centrifugation is a process which actually can be invasive to or it can be detrimental to the sperm, especially if the sperm quality is not good. And hence the force and the time, instead of just centrifuging it for 20 minutes, like you can reduce it to 10 to 15 minutes. Again, it is depending upon the concentration and the quality of the semen sample. And the second key point is, once centrifugation is done, the tube should not be left on the incubator bench. Immediately, we have to remove all these abnormal cells, like the ones which are here on top, like the immotile, dead sperm, epithelial cells, leukocytes, bacteria, everything will be here. And the immature and senescent sperm will be here in the second. So this has to be removed from the, the centrifuge tube. The reason being, initially the sperm is pelleted and it is here at the bottom of the tube. But if you just leave it there, the sperm will start swimming and then, everything will get mixed up. So that's the reason why it is suggested that this two things you have to take care. Now, for suboptimal samples, other few points are like, normally we store our gradient and sperm wash medium in the refrigerator. So before procedure, at least half an hour before the procedure, that we have to bring it to room temperature or, the body temperature. This is because you want to protect the sperm from cold shock. If it is a normal sperm, sperm actually can withstand a lot of these kind of assaults, temperature, pH and all that. But here we are talking about suboptimal. So the quality is already compromised. You do not want to, cause more damage by putting the sperm through cold shock or, like leaving it at 37 degrees for a very long time. So either way, higher temperature as well as lower temperature can have an impact on the sperm, the fertilizing ability of the sperm. Another thing which I would like to mention here is, whenever we are loading a gradient, like we should avoid overloading it. Say, when you just look at this tube here, we see the initial, this bottom layer is around 1 to 1.5 ml. On top of it, we have this lower density gradient solution. That also should be around 1 to 1.5 ml. And on top of it, the semen sample actually has to be again between 1 to 1.5 ml. But if you have more sample, say for example, like, if you have 5 ml and all that, should not load the entire thing in the same tube. Instead, you have to actually make multiple tubes. And what we generally advise is, if the semen volume is more than 3 ml, then I think, it is better to do a third and the fourth tube. So this way, what happens is a phenomenon called rafting can be prevented. Rafting is nothing but the aggregation of all the debris and the unwanted cells before even this, or during the process of centrifugation. Now, some other modifications which we normally suggest is, when the sample quality is suboptimal, is instead of having a 90% and 40% gradient, we suggest 80 and 40. So what happens is here, like you are diluting the sample, that means you get more recovery. There could be some sperm which actually may not be of the best quality because, like the gradient is 80%. But here in IUI, we are looking at an increased concentration, not like ICSI. And hence, it is suggested that like 80 and 40 gradients are used. In very rare cases, 72% lower gradient will also result in an increased absolute yield. But remember, when you do a 72% and say the 36% top layer, this will be like you will end up recovering a lot of abnormal spermatozoa. Okay, so again, the choice of the method will depend upon the concentration, the presence of debris, and other parameters of the semen sample. Another thing is like, see, if you are buying 100% gradient, then in the lab, like you have the flexibility to have 80, 40, 72, 36, whatever. But I do not know how many labs go in for that because many people would just buy these ready-made 90 to 40. Then the embryologist actually should know how do we dilute this sample to achieve the required density by using sperm wash media. And another suggestion is to increase the column length. So as I said, like columns is generally like 1 to 1.5 ml. But if you want to have a better separation, then we can increase the column length to say 2 ml. But here, if you are making 2 ml of 80 or 2 ml of 90 and another 2 ml of 40, then the semen sample actually has to be less. Like if you just add another 2 ml to it, then I think the tube will almost be full, and then we do not get good separation post centrifugation. Now, how do you handle a highly viscous sample? Now, a semen sample is mixed with culture media, sperm wash media. Again, media has to be at room temperature. Media can also be at 37 degrees because, the semen sample will be at room temperature. If you are adding equal volume of media at 37 degrees, it's not going to cause any heat shock. So it can be either be at room temperature or at 37 degrees Celsius. And then see if the viscosity is better. Otherwise, like this sample can be taken in a syringe with a needle of 18 gauge and can run up and down. But remember, like this has to be done very gently because it can actually damage sperm cells. Now, another method is like we can use enzymatic liquefaction with the trypsin. And trypsin, usually 5 milligram concentration, is dissolved in 1 ml of sperm wash media. So in case if the sample is very viscous or if it fails to liquefy, this 1 ml sperm wash media can be added with trypsin, can be added to the semen sample. And all enzymatic reaction will work better only if it is incubated at 37 degrees. So the sample has to be incubated at 37 degrees Celsius. Then for 20 minutes after that, you just mix it, and this can be directly loaded onto the density gradient column. So this way you can reduce or you can handle a highly viscous sample. Now the next method, what I was telling is, apart from density gradient centrifugation, is simple washing. I think there are many labs which actually do this in a routine way. Basically, like to the semen sample, we add media, 1:1 ratio, the sperm wash media, and then mix it gently. And the sample is centrifuged between 300 to 500 G. G is the gravitational constant for 5 to 10 minutes. The reason why, G is mentioned is, it actually, this is a constant value. But if you are converting it into rotations per minute or revolutions per minute, RPM, it depends on the centrifuge. So if it depends on the centrifuge rotor, the distance between the center point of the rotor to the tube and all that. So to avoid confusion, whenever people are saying about like what should be the ideal centrifugal force, it is mentioned as G. So centrifugation is done between 300 to 500 G for 5 to 10 minutes. The supernatant is discarded. Pellet is again suspended in culture media, and again a second centrifugation is done. Now, the rule of thumb for simple washing is, usually this is used only if the semen sample has optimal parameters like, like morphology and debris. If you have a lot of abnormal spermatozoa, or if there are a lot of debris like sheets of epithelial cells or round cells, then it is better to avoid basic washing or simple washing. Either one. If your aim is just to concentrate the semen sample, like without losing anything, you can use it, provided the concentration is less, motility is okay, morphology should be normal, and should not have any contaminants in the semen sample. Because as I said earlier, when there are a large number of non-viable spermatozoa, usually that happens, right? Like the sperm is a mixture of everything, like semen sample has a mixture of everything, viable, non-viable, highly motile, immotile, then slow moving and all that. So when you're centrifuging, like when you have all these things in the same pellet, then it can actually decrease the ability of a normal sperm or a good sperm to fertilize the oocyte. So it is generally it is not recommended, but if you do not have any option, and if the sample is very poor, only in terms of concentration, then simple washing can be tried. Now, to answer this question, is centrifugation really harmful? So in the 80s, they did a lot of work on this, especially, like on the semen sample, the fertilizing ability and all that. And they've published this thing which said that if it is a good sample, okay, up till 800 G can be applied. But if the sample is not good, then, it is always better to centrifuge at a much lower centrifugal force. Usually what is recommended is 300 to 500 G. And if you're talking about RPM, on a rough this thing, it will be somewhere between 1400 to 1600 RPM. Okay. And so this I have already mentioned, that centrifugal pelleting of unselected population, it can actually cause irreversible damage to the spermatozoa, which actually can hamper the fertilizing ability. Now, this is one study which I thought, I would bring to your attention. Two groups were analyzed. The first group had, all centrifugation done at 2,500 RPM. This is pretty high for a long period of time, that to 20 minutes. And, they also did the swim up. The first one was density gradient. The second one was swim up at 2,200 RPM for 10 minutes. The second group, everything swim up, both density gradient, everything was done at 1,600 RPM for 10 minutes. And they found that the overall pregnancy rate per cycle was 3.43% in group 1 and then 10.03 in group 2. So the message from this particular study is reduced centrifugation speed and duration is found to have a positive effect on the pregnancy rates. Now, what about temperature? Because that's another question which we normally get. Should we keep the sample at 37 degrees Celsius or should we keep it at room temperature? What is, there are a lot of studies to show that the proportion of acrosome reacted apoptotic dead spermatozoa actually would be high if you incubate the sample at 37 degrees Celsius for a very long period of time. So what is generally recommended is, after sample preparation, if the IUI is going to happen within the next 30 minutes or so, maximum 45 minutes, we can keep it at 37 degrees Celsius. But if it is going to take much longer, then it is better to keep the sample at room temperature. And then, just before the procedure for maybe 10 minutes or so, we can keep it at 37 degrees Celsius and then the sample can be given for insemination. So what are the options for increasing this total motile sperm concentration? One of the therapeutic options suggested is to pool the ejaculates because, it's been shown that in men with normal sperm count, normal motile sperm, if you pool the ejaculates, it can increase the concentration by 144%. And in oligospermic men, the pooling of ejaculates can increase the sample, the concentration by 329%. This is a low cost way of, increasing the insemination concentration. And this was published much earlier, somewhere in the 90s. So For the first sample, if the patient, if the sample is very less or if it is below optimal levels, then we can ask for the second sample if the patient is willing to provide the second sample. But here, the first sample has to be processed and kept. We cannot just leave the sample like that on the incubator bench, because for the reasons which have been mentioned earlier. So to sum up, when the semen volume is low, it is better to do pool samples and then simple wash. If the count only is less, again, pooling samples will help with simple wash. If the motility is poor, then we can just do a quick basic wash, and then the pellet can be loaded onto the gradient and it can be separated. If we have highly abnormal sperm, like morphologically abnormal sperm, gradient is the best way. And if there are a lot of debris in the sperm, again, gradient is the best way. And if we have gelatinous bodies, flakes, epithelial cells, then all these things can be allowed to settle, and then the semen sample can be taken without disturbing that, and the whole thing can be placed onto the gradient solution, and centrifugation can be done. So to conclude, this threshold, whatever is mentioned, it is actually, subjected to a lot of variation between the laboratories, because, it also depends on how do we prepare the semen sample and how we are counting them. See, samples which are counted on a Makeler can be different from a Newborn chamber, because Newborn chamber, it can actually give you an accurate count compared to what we do on a Makeler chamber. And again, in all these studies, there is no concentration, which can actually say that there is a 0 chance of pregnancy. Even with 0.25 million sperm, there is still 4% chance of pregnancy. So all these cases are candidates of IUI. However, we should keep in mind what to expect from the cycle. And most important parameters are the woman's age and the infertility diagnosis, because you have to look at the count along with these two parameters. Then that can set a realistic expectation for the predicted chance of success per cycle. And sperm as such has to be handled very carefully. But then if you are handling a suboptimal sperm, then it has to be handled very gently, pipetting, centrifugation, everything has to be very gentle. And as I said, the fine tuning or the modification of the procedure, like adjusting the column length, adjusting the centrifugation time, adjusting the centrifugal speed, all these things has to be performed on an individualized manner. This can offer better IUI success rates. Thank you very much.
How many cycles, Sujata, you think in a suboptimal semen sample we need to do to expect a reasonable success rate? 3, 4, or 6?
I think, the sample is very poor. I think 3 should be more than enough, because after that, there is no point in continuing. If that is the only issue, if the sperm is the only issue, I still would suggest that we can pool the samples, get the concentration, try it 3 times, and if it doesn't work, because any day we know that the same patient will have a better chance with IVF.
And how much of abstinence would you suggest before they give the sample?
See, the thing is, less number of days will give you a better sperm in terms of DNA quality. Okay, but if you are looking at an oligozoospermic sample, then if you reduce the abstinent days, your count will further drop down. So it depends on, say, for example, generally 2 to 3 days is okay. But if you are looking at quality in terms of DNA fragmentation, then you can ask them to ejaculate even, 24 hours prior.
So even that advice matters when you're trying to optimize the sample.
Yes.
How many factors go in?
Yes. So the thing is, if motility is the problem, then maybe, a shorter abstinence might help. Or viability is the problem, then shorter abstinence will help. DNA fragmentation is the problem, then again shorter abstinence will help. But if concentration is the problem, then if you do shorter abstinence, you may not get anything. Sometimes, we even see like cryptozoospermia or azoospermia with this short abstinence sample.
And what would you suggest? One single IUI post ovulation is preferable, or you would want a double IUI in suboptimal samples?
The thing is, I do not know, that mostly a clinical call, I think. But then from the lab point of view, I would suggest have multiple samples collected. If possible, if we can even freeze some samples, we can thaw them and then give them one shot with the right concentration.
Thank you so much.
Dr. Sujata, I would like to ask you one or two questions. For the patients who have a high DNA fragmentation index, I know we have to suggest IVF for ICSI, but if we are going for IUI, any method, any specific method to use about the semen preparation methods, I'm asking. Do you suggest some special preparation, or it is just a gradient?
So two things I think would help here, because if it is only high DNA fragmentation, but count and motility are decent, then it is better to have a very short abstinence. Okay, that can reduce DNA fragmentation. And then density gradient centrifugation would actually give you sperm with good DNA quality. Remember, like when I was in, with Cloud9 earlier, we did a study on few patients. Okay, so patient came, we did DNA fragmentation. Then the same sample was put through density gradient centrifugation. We did DNA fragmentation, and then we also asked the patient to give a second sample, and then we did a DNA fragmentation. What we realized was density gradient actually, substantially removes sperm with high DNA fragmentation. So the pellet itself, greater extent has very less DNA fragmentation. And then we also realized this second sample, which we were collecting on the same day, that also reduced it by significantly. It reduced the DNA fragmentation. So these two things actually can be tried. Those samples are actually for IVF, ICSI. So that is why we all had that microfluidics also that time. And then we realized that microfluidics further, there were so many cases where we got 0% DNA fragmentation post microfluidics. But that is for ICSI. And, where the concentration was not an issue. But for IUI, I think these two things should help.
Okay, thank you.
The question in the chat box: exposing the post-wash semen sample at room temperature, does it affect sperm motility?
No, it wouldn't affect sperm motility. Okay, like room temperature means like we are, looking at 25 degrees Celsius, because, many labs, when I go, I realize it'll be very cold. When you look at the room temperature, it would be 22 degrees and all that. So we are talking about 25. At 25 degrees, it should not affect the motility. But since the sample is for IUI, a little bit of, initiation of all that capacitation might help. So we just say just before the procedure, you can keep it at 37 degrees for 10 minutes. But otherwise, it can be kept at room temperature. It doesn't affect the motility.
There's another question. I guess this is an ideal candidate for ICSI, but still the question is occasional motile and immotile sample. Would you suggest an IUI for it? I think it's...
No. Because, see, in our system, right, like we were talking about IUI pregnancies, okay? Like this kind of discussion was going on for a very long time. But then, they would say that some labs, why is the IUI pregnancy very low? Whereas in some labs, it's quite okay and all that. The benchmark was 16% in our system. So the last year, I think we had done some 4,000 IUIs or something across all our centers, and we analyzed. And we realized that when the concentration was less than 2 million, okay, the pregnancy rate was, 3 point some %. Whereas when the concentration was above 10 million, our pregnancy rate was far, much better than the benchmark. So this is a very clear indication that the choice of cases is also important. But then, sometimes, and then we also spoke to the consultants, some consultants who were regularly doing IUI in such cases. And the feedback we got was like many a times patient would want, like they do not want to directly go in for IVF, and hence they would want an IUI done. So if that is the case, we do not have any opinion on that. But then if you're asking the lab, a sample with highly motile sperm or rare motile sperms, it is better not to try IUI.
So thank you, Dr. Sujata. If there are, Priya, if there are no further questions.
One more question.
Yeah, you can ask a question.
No, audio is getting stuck.
There are some questions. They say, ma'am, sometimes the count is 40 million per ml, but the motility is only 3 to 4%. How to go about for the sample preparation of these patients?
So what type of preparation is better?
Okay.
Yeah, that's
So
what.
density gradient with a higher 90%, 45% would be better. Because, that actually would segregate samples based on their motility. So 90, 45 gradient would be better, density gradients.
Nowadays, we have recently few other types of sperm preparations, such as the magnetic assortment. And what is your take on IUI samples? Do you suggest?
That actually magnetic assorted samples do not, you don't get good recovery. So for IUI, you need, sometimes we feel that even for IVF also, that's not enough. If it's an ICSI sample, it is okay. But IUI, I don't think. But I believe in the market, you have microfluidic device now specifically made for IUI preparations. I have not used them. I have used microfluidic device for ICSI samples. But, I heard that there are devices which you can actually use for IUI samples.
Okay. Is there any situation where you've cancelled an IUI? You have suggested don't put this sample. Is there anything after preparation? Have you come across any situations in your day-to-day practice? Something like the sample was pre-wash was better. So the count is better, but something you discovered in post-wash, you feel, you suggest the consultant not to go ahead with an IUI, something like that, any situation?
See, sometimes what happens, initially when you look at the semen sample, you will not see it. But then after you centrifuge, you will see some red blood cells and things like that, which actually would not be separated by the density gradient. So those cases actually we have informed the consultants. But otherwise, I've never had any this thing, where we have cancelled because of the, post preparation.
Okay, Sujata, one more thing. Do you suggest semen culture nowadays? Is it advised or before IUI or IVF?
It's always, I think, in IVF, it matters because there are many incidences where we have faced a complete washout of the culture in spite of doing ICSI because of bacterial contamination. Patients coming from abroad, semen culture not done, they would have had some treatment earlier, but then they would not have had any antibiotic before procedure. So all these things can actually, and especially if you're doing IVF, then it's all the more reason that semen culture is recommended.
Actually, we are seeing more and more positive cultures coming up. You don't see that many WBCs in your semen thing. It doesn't cross the tangents, but you find, there will be some clumping or, it will have motility only in its place, no progressive motility. Probably suspicion should be there. You will get some growth definitely coming out. Plus examination, personal hygiene of the patient also makes a lot of difference. I think in the clinic, what we're seeing is almost around 48 to 52% is what we got. Culture positive.
That's really
almost
good.
Half our patients are getting very, very, and it's growing all sorts of bacteria. It's not that, it is only one type or something. And you'll find similar thing in the wife also. If they've had a sexual intercourse, you do a swab test or something, you will get a similar thing or in the group. This is what I have found in the practice.
How long will you wait when it is positive So after the treatment, because we are doing in the cycle beginning, if you get a positive, how do we manage? If they are on
No,
antibiotics,
actually, we do it the previous cycle itself. At least
Okay.
14 days prior. Treat at least 14 days. 7 to 10 days is what it takes for it to become. And then you'll get a sterile thing. So I think doing it in the previous cycle makes a lot of sense in this.
So there are two other questions in the chat box, ma'am. One is the sperm sorter, can it be used because it avoids centrifugation? So so routinely using sperm sorter is a question. So
Can
that
be,
is
because like it can be used as long as you can recover enough number of sperm.
okay. The second one is if it's a seronegative, serodiscordant couple, like what is the type of IUI preparation you recommend for them?
So density gradient definitely followed by swim up. Because even in HIV cases, like 99.99% it removes all the virus. Okay, so it is, and then they also say a triple gradient, like 90, 70, and 45. Plus, the pellet has to be, subjected to swim up. So this is what is recommended.
Initially, we used to do 4 levels, 90, 70, 50, and we had a lower concentration, and then the pellet was drawn. I think earlier, whoever's practice had done that. Then it went to 3. So now at least 3 gradients is what we push for all the viral infections which are there.
Yes, madam. Thank you. Thank you for the elaborate discussion, madam. Thank you. So I would request Bhuvneshwari, madam, to invite the next speaker.
Thank you so much.
Thank you, Priya. We know IUI is the basic treatment modality in any ART center, but it is the commonly done by all the ART level 1 people. And we need to really understand what is required and what are the prerequisites and indications. General indications are there, but there are no indications also sometimes just because of the patient request and we want to hurry up the treatment process, it is done. But what is ethically advised? What are the unconventional indications of IUI? That is very important for us to know whether to do it or not. Most of the time, they are all not in the book. So we have to, every patient situation is different. When we face these unconventional indications, we need to know whether it is justified or not, because IUI comes under ART law now. So we need to understand what are the unconventional indications, should we do or not. So I would like to invite Dr. Nandita Thakur, who is a very good speaker and academician. She's a medical director of Nandita Fertility and Research Center in Chennai. She's an academic head and coordinator of Mehta Hospitals. Her area of interest are reproductive medicine, high-risk pregnancy, genetics, lifestyle, and gynec disorders. She is very much interested in teaching and she is focused on a lot of training programs and conducting a lot of webinars and conferences and spreading the knowledge. I would welcome Dr. Nandita to give the speech on unconventional indications for IUI. Over to you, ma'am.
Yeah. Thank you. Chitra, can you share my slides, please? Okay, unconventional indications for IUI. I thank the organizers for giving me such a topic for discussion. It's tough. At the same time, yes, we have to think out of the box. What is it that am I looking at? So slide, please. Next slide. Yeah, these are common. If you open any textbook or you search on the internet or whatever it is, these are the most common things that we find. You have male factors and you have female factors. So what is unconventional indication? What is out of the box indication? I was very much, putting, next slide. Semen allergy is something which I thought is less spoken. I have seen only one case of semen allergy, probably referred to me by a dermatologist. There they say that, the patient just presented with the first intercourse and she developed some allergy on the external genitalia and slowly it became a spread infection. So when I did this, of course, they never came back for IUI or something. This was way back in early 2000s. So when I looked up literature, I found about in the US, we have 40,000 women per year being reported, which is quite a significant number. It is related to prostate-specific antigens, and it's believed to be one of the major causes of allergen. 40 to 50% have systemic or localized seminal plasma hypersensitivity, and usually present after the first time intercourse. In certain cases, the reported cases which I went through literature, they say it can even present as a delayed hypersensitivity reaction. To identify this, now we have positive prick skin tests to look for the immunoglobulin. Slide. Next slide. So this is how it appears. These are pictures taken from the net. You can go through this. So this was the paper published in 2011 when all these things started coming up in a bigger way and people started publishing their data on this. Slide, please. Next slide. Okay. So this one particular case which was reported, I thought it was very interesting because they say successful pregnancy after an insemination. This lady had her 8th IUI cycle, okay, and that's where she conceived. Of course, 8 is too much for big, but probably in the early 2000s, IVF, this patient was either not willing. So they did separate the sperms. From the pellet, they started putting a drop to see whether the patient developed allergy. The results of the stripping patch test with 10% diluted semen and the semen pellet was seen. Then they found hypersensitivity reaction, which is seen on the upper image B. So they went on to do a second wash and they found where they diluted further. And after 4 washes, they found the erythema to be very, very less. That is the time they did the insemination. Of course, this turned out to be a positive pregnancy. One case report detailing the process of semen preparation and doing the IUI for a successful pregnancy. Of course, each lab will have its own protocols, but this is something which was spoken in detail. So I thought I would share this data with you. Next slide, please. Slide, please. Yeah. Women above 35, below 35. Okay, below 35, good enough. We can all offer IUI if they have come, no treatment and all that. But when it is added with a factor like a low AMH, most of us would jump to say, yes, can we look at IVF as a treatment because your ovarian reserve is low. So there was an interesting article in Fertility Sterility in 2020. This group looked at patients below 35, documented a low AMH. There are cutoffs. It's a very nice paper. You can go through patent fallopian tubes and a motile count of more than 10 million at that time. So they say this treatment, they matched the controls, age control, and they found similar rates in both. So below 35, less ovarian reserve. Can we think of IUI? Yes, if the sperm count is good, tubes are patent. They had similar outcomes. But above 35, yes, that's the next challenge that will come up. Next slide, please. Can I have the next? Yeah, above 40. Just okay. So there were a couple of papers which I looked at. Please press enter Chitrakala. There are 3 lines in that thing. Yeah. So they looked at as early as 2002. They said above 40, we did not have access to IVF in many, many places. And they would continue to do IUI. Here they found the rate between 40 to 42. It was around 9%. Here the semen parameters were normal. Of course, it is low. No, please wait. Go back to the previous slide. Previous slide, Chitra.
Chitra, can you go back?
Yeah. The paper which came out more recently, okay, they studied the live birth rate to be 0.3 per cycle and 0.7 per patient. This was done above the age of 43. So 40 to 42 seemed to be a gray zone, whether to opt for IVF as a first option or IUI as the first option. Here, the patient would actually dictate, in spite of us as consultants repeating most of the time, we would like to go for a higher fertility program. I think all of us experienced this in our patient clientele. Then, what did they say? They said, let us compare natural cycle IUI and a stimulated cycle of gonadotrophins. They found the results were almost equivocal. So if the patient had regular cycles, they said they did not even do oral medication and compare natural cycle. They found the rate was no different. Okay, so are we justified in doing natural cycles in this? This probably could be an indication, or it can be considered as an indication of not using gonadotrophins. That is a totally debatable point for us to see. Slide, please. The next is long distance relationship, which we all come across. What is the options? Slide. Just press enter. Yeah. So this became one of the things. Can this be? It is not recorded in any book or anything, but yes, there are anecdotal. Few people do talk about this to consider artificial reproduction. Can the patient go back to her partner during the fertile period, or can they take a vacation together, or he is traveling at that time? What can I do? So probably it is one of the patient factors that say yes, we can think of freezing the sperm or doing an artificial insemination at that point of time. And to match the ovulation of the cycle. Yes, there are, this causes, it probably, this was done by Nicole Moore, and they have presented earlier some papers which I came across. They said that, it reduces the patient's stress because they know, okay, at least this cycle, there is a possibility of having, a chance of a pregnancy because the sperm is available. And she is a healer also, a psychologist, and she has given certain talks also. So this is something which long distance relationship is slowly coming up because we have find husbands somewhere, wives somewhere, or their times are just not together. They are not able to come to the clinic. This is the thing which we see in the present day as one of the unconventional indications. Next slide, please. Okay, vaginismus we all speak about, we all talk. And Lamotte and Patrick gave a grading. So in the first three conditions, probably the patient with counseling, talking and doing vaginal dilatations, repeated counseling can help. But grade 4 and grade 5 is now probably coming as indicators slowly to come for IUI. There are a lot of papers which have come on this. Slide, please. Next slide. Vaginal penetration phobia. This is something, in 2017, the paper was published, and where they say even vaginal penetration, you cannot even use a vaginal probe on these patients. Fear of pregnancy, fear of penetration is very, very high. They say they may choose to have an IUI because they want to have a child, but they don't want the part where it can be natural. Where the women have very high stress factor on that. So this is something which was IUI can be suggested in such patients. Next slide, please. Stress infertility and asking for IUI. Stress, did a review from 2017, 18, and 22. We had reasonably good number of papers. Timed intercourse, when it is very, very stressful, the act does not happen. The men almost go into a phase, they get erectile dysfunction, delayed ejaculation, anger, not necessary, they become aggressive. Probably a stress and a demand for IUI is slowly now increasing because of a lot of other, environmental factors. The next was another study where they said the treatment of men, the men who are having post-traumatic stress, that is, they have gone through stress of infertility, come out of it through counseling, medication. This was written even from a psychiatric point of view. They say the percentage of pregnancies and IUI procedure was slightly higher in patients, in men who were treated with post-traumatic stress disorder compared to the control group. A combination of psychotherapy techniques and ART, such as IUI procedures, increases the chance of healing infertility in such group of patients. So this was a large study which was done and published. So this also could be one of the factors probably contributing to the number of IUIs that we are doing. Slide, please. Discordant viral infection. We had HIV. We had hepatitis B. We also now getting added into that HCV and HDV. So good clinical practice service should not be withheld. You treat the partner appropriately with the vaccine or the antiretroviral. Then once it's okay, they can take the couple up for doing an IUI, proper semen washing, and then you do the IUI. Of course, we do know that HIV positive, but to add to that, you have HCV and HDV coming in through because we're getting more reported cases. As far as literature goes and literature survey, this was a few of the papers that I had come across as indications for IUI. The rest, I would keep the questions up, and thank you very much. It was very interesting to do a search on these papers. Next slide, please. Thank you, one and all.
Thank you, ma'am. It was really eye-opener, out of the box thinking, and most of the time we see these kinds of situations and whether it is justified or not. Thank you so much. Any questions, Priya?
No, ma'am, not yet. I think the audience are like, full, they could not come out of the webinar yet, I think so.
Dr. Nandita, there is a particular doctor was asked a question that soon after intercourse, she gets cough and she feels all the semen is coming out. And could this indicate like this vague behavior post ejaculation? Could allergy be suspected?
Allergy may not be suspected, but one of the phobias have to be ruled out. Okay. Fear because this patient might be infertile or they might have a psychosexual problem, which has to be looked at. There is one case report which I came across when I was searching, patient presenting with cough and allergen, want to go and wash off or something. They said you can think of a psychosocial problem. It was an anecdotal case report only. Probably I can share it later. But having cough immediately after intercourse doesn't relate to semen allergy.
Okay. And if zero discordant couple, what's your suggestion as a preferred IUI preparation method?
It could be gradient only. No, I think Sujata has mentioned gradient is one of the best.
Yeah. So those are the questions which I had seen on screen.
Ma'am, for vaginismus, you said like, IUI could be an option. So most of the time, like single finger penetration or TVS probe is difficult. So any specific, take-home points or tips you're going to tell us to how to put the speculum and how to go about with an IUI process for a patient who is like really sensitive.
Nandita is going to say instead of IUI, do the vaginal. Just put in a thin catheter and put it in the vagina. Yeah.
Probably that will be, the answer, which I have done in quite a few cases.
Yeah, when they
have, and the couple will understand and they do home insemination many a times. They have come, even doctors have come to me and say, home insemination, we have tried, it's not worked. Now can we go for IUI? They just don't want to have the regular relationship, but they want children out of it, not children out of the marriage. So the first one, I had a very young, I would say young definitely because they were in their 30s. They had the first child with insemination at home. Second, after 8 years came, they said, we want a second child. They have tried 6 inseminations at home, not worked. So they want IUI. So very difficult to do even a, transvaginal. I only did a transabdominal scan, and how correct it was fine. We did 3 IUIs and then 4th IUI, she conceived. So it's just like, it's very difficult. We do see these difficult patients, but yeah, we have to, take it with a pinch of salt because it's finally the patient's choice how they want to have a child.
And then what do you think, like when there is a single patent tube, okay, and you want to do the IUI, right? So once one thing is obvious, like we have to wait for the post ovulation, but when there is a double uterus and all, would you maneuver the catheter to the side of the patent tube? Like, would you make some twists and turns within the uterine cavity if there is a uterine anomaly?
See, if there is a septum, yes, you can think of this side. But if it's just an arcuate uterus, that is really does not matter.
And there are
to maneuver it to the side, what are you maneuvering? Because the semen is going to be motile. It's not going to sit there and say, okay, I'm going to swim into the right tube or the left tube. So just inseminate from below. This good sperm will definitely find its way because it's more like a chemotactic effect. The chemical reactions will draw the sperm towards it.
And with long distance relationships, do you find the request for IUI being more long distance relationships? They just say, just tell when it's happening. We don't have the time.
Yes. We are seeing more because they are willing to freeze the sperm. They come back and, do the IUI, or the husband is just going away that particular month and he's leaving, say 3 days later, not yet inseminated. They come and say, okay. Then they come back, the next time he's here. By the time the women get smarter, they'll say, when he lands, I should do one IUI before he leaves. If it doesn't work, the second IUI. So I think we are manipulating a lot of cycles, which over time that I have, it's, evolved. with the facilities available.
And you
Ma'am,
are
regarding the, okay, gotcha. Okay. No, just for the completion, regarding the ARTILA, there are a lot of other situations like, can we touch up on those and can you just throw some light on that, like single women coming and living relations and homosexual, all those conditions indicated as per our new ARTILA. As per
okay. See, for our law, a lot of things are still not, become by law. When you go abroad, lesbians or homosexuals, when they want to have a child, you have a surrogate. See, if it is two men, okay, then they have to think of a surrogate. It's a surrogate, whether it will be their own egg or it will be a donor egg in that surrogate. There are so many multiple permutation combination. This particularly, I left it only for a discussion. I didn't even put it as a slide. When you talk about women or lesbians, okay, then what is it they want? Who will bear the child? That is one. Then you need to go to the donor bank to choose the donor. Some people come and say, we want out of this. So there are a lot of legalities involved in this. In our country, still those legalities are not very clear, not very defined. So I think we have to wait for the law, abide by the law, because finally the single parenting and all, it will take its own, course. And who will be responsible? So, finally it will come on the doctor. You should have seen this. You should have done. This should have been the law. You should have spoken. So I think, we need to go through that cycle properly, have definitive guidelines. See, once the, once the judiciary decides that, yes, this sort of marriage is acceptable by law, then you will have guidelines framed for this. There are guidelines in certain countries, which I am aware, but in India, we do not have set guidelines. Even our basic IUI itself, we are thinking, oh, where will I get the donor sperm? Will I get from this bank, that bank? So we are still in our, infant stage. We still need our guidelines more in place. We never thought about this when setting guidelines.
Ma'am, we have
and how many of them? Yes, sure.
We have a suggestion in the chat box saying why don't you do IUI under anesthesia? So what is your take on it?
Okay, IUI under anesthesia, severe vaginismus, yes, I have done in very selected cases. There was a couple of patients, of course, one was a medical doctor in our own hospital. She used to apply, lignocaine and come 3-4 hours before. And she'll say, I'll apply lignocaine, then you do a PV, and then you do one thing. So it was like, those sort of things. So doing under anesthesia, yes, externally they apply because it's only the first third of the vagina, which is more sensitive. Inside, we all know that you can do. So we have tried this. I have tried even, under anesthesia in very, very severe cases on request. But yes, these are situations that we have to tide over. These are practical things that we have to tide over. It's not that every patient who walks into the door.
Are you telling about only the local anesthesia, or are you talking about even the GA and going ahead with IUI?
I'm talking of both. Okay. Some, like this particular set of patients whom I knew, they were all staff nurses, or they were doctors, or they had some knowledge, who applied lignocaine and came to the OPD. The ones which the stage, vaginismus grade 3, 4, and 5, where you see, but they're very particular. They don't want to tell at home. They have not consummated. In that, I have given GA and done. Of course, it has worked because there's no other factor.
And one question, nowadays we get ectopics, and after ectopic, with one tube, they come back and they come for fertility treatment. So is it which side the ectopic and which side the egg is going to ovulate? Does it have any decision-making difference in you for the IUI? Because some people choose on that as
psychologically, the patient will say, is the egg growing on the right side? So the right tube is patent. Okay, but whenever you give some, ovulation induction agents, invariably you'll find follicles on both the sides, especially this side. This type of patient, you can add a smaller dose of gonadotropin so that the patient is comfortable. You could say it's growing both sides, let it hope it will.
If it is growing on the opposite side, so do you abandon the IUI and say, no, I'll not do?
It's on patient's request. A lot of patients opt out of IUI at that time.
But we
There is
don't
no
see,
scientific basis. There's no scientific basis.
we say
on
still
this.
the sperm can swim up that side also, or the
We
egg
don't
can
know.
migrate.
We don't know.
Yeah,
we don't know. Like, we don't know. That's what it is.
True, ma'am, true.
They have finished the questions in the chat box. I think.
No other further questions, ma'am.
So thank you so much, Priya Kandapan. You did a great job hosting this program for us, and my co-chair,
Thank you,
Dr.
ma'am. Thank
Shri, and to all my three speakers who have given newer insight to something which we do day in and day out. IUI, what's there to talk about? But then there's so much to talk about it and interact about it. And I'm so glad that we've had a great audience who've been logging on and interacting and getting their doubts clarified. So thank you so much for making this webinar a successful one, and looking forward to more interaction at another opportunity. So
Thank you. Thank you for the opportunity.
Thank you.
ma'am.
Thank you. Thank you.
have a great weekend, all of you.
Yes, ma'am. You too.
So Chitrakala, I hope you took some shots of all of us together. So thanks
Yes,
to
ma'am.
you and
Yes,
Sheikh
ma'am.
Mama for hosting this program for us. Thank you so much.
Thank you, ma'am.
My audio got disconnected, internet got disconnected, sorry.
Okay.
Okay.